Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki eko weshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Well, good morning, everybody, and welcome to October's Family Medicine Ground Rounds. It's my pleasure to introduce our speakers. My name is Doug Archibald, and I'm the Director of Research and Innovation for the department. And I'll introduce our first speaker. And our first speaker is Dr. Alison Eyre, a bilingual family doctor from Centretown Community Health Center here in Ottawa. And she cares for a full scope practice with a focus on frail, homebound elderly, and new Canadians. Centretown uses a team approach to the most vulnerable in our community. Alison is also involved in multidisciplinary research into aspects of services to vulnerable populations. She's worked in community health centers for over 25 years now. Alison was our postgraduate program director at the University of Ottawa here in the Department of Family Medicine from 2011 to 2017. And prior to that, she was our international medical graduate director from 2006 to 2011. She continues to work with the university in medical education, and she is currently the primary care lead for eConsult in Ontario and is actively involved in the Ontario health teams, Kids Come First and the Ottawa OHT. Alison has worked internationally with the Red Cross in Sri Lanka and Haiti, doing disaster relief and program development. She's a mother of 3 and thinking about being more and more involved as a craft person. So without further ado, Alison, over to you.
Sorry about that. That got sent to you quickly. I am not the lead of eConsult. That's Marilyn Crabtree, and bless her heart, because she does a wonderful job of it. So I want to introduce you. Thank you very much for having us here today. You're going to have 2 talks from Centretown Community Health Center. So I'm just going to give a little bit of a sense of how it works. So our setting, Centretown is a community health center in downtown Ottawa, as was mentioned. We work with multidisciplinary teams. It's a salaried approach. We offer services to all ages, and within our primary care team, which is only one of the teams at Centretown, we have doctors, nurse practitioners, nurses. We are blessed with outreach teams, and we have specific nurses for shelters and community support workers. A lot of the research you're going to get today comes out of our urban outreach program. Centretown has done urban outreach for many years. The focus is on people who have limited access to primary care and mental health services, often people with no OHIP. The homeless or vulnerably housed. We work a lot with refugees, sex trade workers, a lot of focus on substance abuse, particularly during COVID. This has been incredibly relevant. And beyond primary care, we have showers, harm reduction, exchange, social services. We help a lot of people get ID and housing. So it's generally a pretty holistic approach to the vulnerable population. Centretown has a long history of this. Generally, in about 2005, we did some research into what were the barriers of care for the new Canadian population, and we actually separated them out in terms of their services from the rest of the urban health focus, though it's still one team. We have 2 days of walk-in clinic for urban health a week and 2 half days, and then 1 half day for booked new Canadian appointments. And so you can tell during COVID, we certainly did not close down. There were 393 unique individuals served during the first quarter of 2021 alone. We never did close these services down to in-person visits. So class, I just they talk about one of the things that we've realized within this population is it's quite hard to be able to refer a lot of these people into tertiary care hospitals for many reasons. And so thanks very much to work that Carol and Toby Oldson and others did. The pediatricians and the residents come to Centretown, and all of the health centers can refer into this service, but it allows the patients to be served in an environment that's much more comfortable to them. So and just Centretown's commitments to learners, we always have PGY 1 and 2, we have multiple medical students, we have residents who come through, nurse practitioner students, and we participate. You're going to hear about some of our research today, but we also participate in research from the coalition. So our project, this is set in such a way that I can't see my own screen. So we're going to talk about the feasibility and accessibility of a modified social determinants of health focused pediatric screening tool today. And we got the prime funding in 2016, and our initial hope was to create a social determinants of health screening tool that could be used very much in the transition of pediatric patients from the community to hospital. We hope to try it out, but a lot of things happened on the way to Rome. There was an explosion in the literature. There were many of these tools created. We had a terrible time recruiting participants, which I'm sure is something that you guys have talked about at these rounds. We also had quite a lot of staff turnover, which just made it very difficult to get continuity when we could get recruitments in. So we kind of figured out, how can we use this? One of the gaps in the literature was around accessibility and feasibility of these kinds of tools. The survey tool that we had created to work with was actually very suited to being able to access that kind of information. So we switched to using a purposeful sampling approach, which allowed us to saturate our themes. Sorry about that. Okay, sorry. So an overview of the literature. So as I mentioned, there's increasing, there's a lot of evidence that social determinants of health are extremely important in the factors that contribute to ill health. This is extremely important in the pediatric population, though few pediatricians or GPs routinely ask or address these issues, despite the fact that in 2006, the American Academy of Pediatrics policy endorsed a process of using screening tools. So we did, our databases were Medline, Nursing and Allied Health, and CNAHL. Search terms were logical to what we were doing: social determinants of health, access, equity, inequity. In 2016, there were 173 results. By 2020, there were 750. And so that's just a visual of what that looks like. So this is just a slide that tells you there are multiple tools that have been validated in different ways. And I love this because this kind of shows how complex social determinants of health is. It's a graphic that one of the librarians at CHIO did to just sort of map out how complicated social determinants of health are within our structure and communities. So There were few of these publications that were on acceptability, and there were also only a few publications on risk. And so we moved forward with our research. So this is just a bit about our data. So our population was, fortunately, we were very female oriented, and I think that that may just say something about primary care and pediatrics. But we did have a wide variety from nurses, nurse practitioners, social workers, pediatricians. People worked in a wide variety of setting and had a various scopes of practice. We really wanted to make sure that the providers we were talking to actually did work with the populations that we felt were affected by or impacted by social determinants of health. And yes, they all worked in the populations that we were looking to. So when we did our themes, we did kind of an evolving thematic analysis where we devised our nodes. We used in vivo, and we devised our nodes out of the themes that were coming out of our interview. For that thematic analysis. So the frequency of points that occurred, a lot of people talked about acceptability, as we've mentioned. Logistics was mentioned quite a bit. Feasibility, pros and cons, risk, and privacy. So we're going to look into those just a little bit further. So acceptability, 8 people commented on acceptability, and people felt that it was a good idea, but they wanted to make sure that it was done correctly, and they felt that it would make a big difference to how patients were dealt with, particularly in the hospital system, if it was understood the impact of the social determinants of health. So aspects to improve accessibility, a lot of people felt that people needed to be trained on how to do this. You couldn't just come out and blurt out these questions. There was a huge need to normalize it by giving context. It has to be done sensitively, without judgment or stigma. It's really important to normalize the data. I haven't just picked you out for this. This is what we do to everybody. Logistics was mentioned a lot. As you can imagine, everyone's overwhelmed. Time, how long was this going to take? Would it be in computer versus paper? Because obviously that has such an impact in our lives. Now, who was to administer it? Was this something that was going to be administered by the physician in the office? Was it going to be done by a social worker, depending on where it was? Was it to be administered? And as mentioned earlier, what kind of training was going to go on? So 7 of the participants commented on feasibility, and they all felt it was feasible, but as you might imagine, they had some comments on that. So pros and cons of feasibility was that people felt they would feel comfortable, but they also felt that it was important to do, unless we really do a good education around this, it is hidden. A lot of these themes are hidden, and if you address them, what impacts you make on yourself, how it can help make a huge impact on your colleagues' ability to provide better care at the specialist level. Because this was one of the things we were really looking at, is that if you send a child from a primary care into specialty care, if they all get dealt with at the same level of education and the same level of information, the social determinants of health may block that child's ability to gain good health care. But there were also a lot of hesitations of the cons, and someone who had been in the business a long time was just worrying about, would this impact the relationship if you were reading off from a tool? And that really goes back into so many of the other things we mentioned about training. So there were a lot of people who wondered about the risk. In general, might this bring trauma to people? Judgment, people were cautious about judgment. Maybe the information would be outdated if we were pulling some of the stuff from an electronic health record. Privacy, risk to confidentiality, and stigma were all really important. We'll just go over those quickly. Risk to privacy. So really, once again, back to being a trained person, and that people would be able to know where it was documented, so it was confidential and private, were really relevant. Judgment. So I think I don't think it's only people don't want to put their income in. I think rich ones don't want to put it in either. So just that sense that nobody really wants to give this information. So you've got to do it really sensitively. And that was really, really, really important. The other idea was not pigeonholing people. This person gets more the title of their social determinant of health as opposed to their name, really wanting to make sure that this didn't add further judgment. into patient care, because as we all know, judgment is a huge part of patient care, unfortunately now. So confidentiality, and that's just a huge issue in any information we ever take from a patient. It has to be talked about ahead of time, that where it wouldn't be shared, but if it was going to be shared, what is the circle of practice? So I think there should be the usual statements of confidentiality, the context, like this is interpreted in the light of your overall health status and your well-being. So back to training and standardization in a sense in that way. So stigma risk, hopefully people don't feel stigmatized. That's the only harm that this person could see. But they really felt that it was important that people don't feel stigmatized with the information. So just in discussion, I think I actually went through really quickly. Ultimately, we had a very small study, but we hope it contributes to the body of evidence that care providers understand the importance of social determinants of health to their patients and would be willing to integrate this into their practice. Or what matters more is what matters more than what tool is used is how it's used and by whom. And that came out so strongly. And then what is done with the information afterwards to ensure that it is connected to the support that they identified being most important to their unique context set and their self-determined needs, so that this information is really dealt with sensitively to help that person's healthcare as opposed to stigmatize them and make their health problems worse. And any kind of time that we would implement a standardized approach to screening for social determinants of health, we should do it with caution, recognizing that the validity of the screening and the outcomes are dependent on the context. So provider training and connection with community resources so that people are giving information and their information is used to benefit their health. So we are disseminating here at Rounds right now. We are in the process of writing an article, and we'll look at putting into various conferences now that we have our data to do that. And so here are our references. And thank you. I want to just go back, actually, if you'll forgive me for 2 seconds. Can I go back for 2 seconds?
Of course.
Oh, no, because I've gone black. I can't go back. I want to really acknowledge that there was a very large team. No, I'm totally black. I want to acknowledge that there was a very large team that was involved with this, that I went through much too quickly because I was nervous. So if you just give me 1 second to acknowledge all of the people who were involved. Did that give you my screen?
Yeah, yes, it does.
Okay, so Toby Odeson has been, she and I have been the main ones working on this, and I don't know if she's on this call today, but she has childcare issues, so she's helping. But the initial co-investigators were Sarah Funnell, Lindy Sampson, and Janice Cohen. The team was a large team. We met frequently throughout. Doug was part of a lot of this, and Sheena Gulani, Huneda Abi Haidar, and Soa Corsand have been really helpful with the writing where we're going right now. So I really want to acknowledge that while I'm the only one here standing and speaking, this has really been a team effort the whole way through. So then I will stop sharing.
Alison, thank you so much. That was a great presentation. I'll now open the floor to questions. So if anybody does have any questions, just put your hand up and we can begin. Actually, I'll start, if you don't mind, Alison. You've spoken about the roller coaster ride of research. I think some of those highs certainly are in some of the findings that you've had, but you've had some lows too, right? You mentioned some of those in terms of recruitment, especially. And I was just wondering if maybe there's some lessons learned, things that maybe you might do differently next time. Any thoughts?
Oh, there's a ton of stuff we would do differently next time. And it's interesting watching the research Carol and Andrew are going to present, because I'm watching them run into some of the things that we ran into right now. I think understanding what recruitment means, it's funny, this has hugely impacted my life. Every time I'm asked to do a survey, I do it because I think physicians never do it. So I do it, and I tell the people I'm really doing it because I know how frigging hard it is to get a physician to give you any time to talk about anything. And forgive me, I don't tend to come to these rounds, but I hope it's something we discuss as a department, that if we believe that primary care research should happen, then we actually have to be willing to do interviews. I don't mean to say that in a judgmental way. I'm a gray hair old lady. I don't have children running around at my feet. I have more time than most people. But I do feel that it sort of surprised me how very, very difficult it was to get anyone in healthcare to give any time. But I also think that we could have thought about it differently. We didn't offer, I guess it totally irks me to have to offer reward physicians to do research. That just seems nutty to me, but I guess it's the way that it has to happen. But I also think we could have really thought about, if we had put into our ethics to do something quick in the waiting room, that would have been a significantly better way to get patients. At CHEO, if we could have been talking to patients when they came in, if we could have figured out a way to have something quick to get responses back. I know now, I think I would have been, Toby can jump in there if she wants to, I would have been much more creative in how to get feedback, whereas we stuck with an image of much more we're going to do this interview, we're going to have it this way. And I think now I would read an enormous amount more of the literature. I know there was just an article in the CMAJ about patient participation. I think I would have learned a lot more about that before.
Thank you. Any other questions, comments?
Alison,
Yeah.
do you see actually using this tool or moving forward with the original vision?
No, I don't think we would use this tool, mostly because there are so many tools that have been developed now and validated. As you know, the hardest thing with a tool is actually going through the whole validation, and that would take a huge amount of work with this tool. And there are really other great tools out there. I do think, particularly at Centretown, as you know, we're looking at, with your guys' research, some of the difficulty of using different tools. But I think if we could find one that was quick, I think it would be very useful, actually.
Do you think CHEO has that on their mandate?
You know what? I'm going to tell you that Lindy Sampson was very involved in this research and is very keen about it. CHEO was extremely active in the discussion of this. So how that would or would not turn into reality, I can't say, because I'm certainly not part of their leadership, but I can say that they have a big focus on social determinants of health and are exceedingly aware of how it impacts their population and how they probably miss things quite often. But I don't know if Toby's on or anyone from CHEO wants to answer that further.
Alison, there's two people with hands up. I saw Gary Viners first and then Yolanda. Go ahead, Gary.
Hi, Alison. Great presentation. I guess when I think about this, I try to look at it from the patient's perspective, and I'm trying to imagine how they understand or understood how this information was going to be used before they're going to be willing to really participate or before they're willing to divulge. And understand how it's going to be stored and how it's going to impact initially and how it's going to impact in the long term. And I'm just wondering if you can go in. You went through that very quickly, and I don't think I caught the answers to that.
Gary, that's an excellent question. I think it's because we didn't have answers. This was not, we were looking for themes that people would bring out, and you have perfectly stated the themes that many, many, many people stated. And I think all of that is really relevant. I mean, if you think in our professions, we sit down and we ask people to say everything intimately about their lives. These are further intimate details that we would be asking people. And it behooves us to ensure privacy, to ensure that they know how it's being used, and to discuss with them. I think patients often have no understanding what the circle of care is. So we weren't really looking to answer all these questions. We were looking to hear the themes, and you have brought out the themes. That's actually why we hit saturation pretty quickly on these themes, because they came out loud and clear. Do I know what to do with them? It goes back to the training, to the risks, to everything that people identified, that if we're going to use these kinds of tools, we have to mitigate the risks, we have to inform the patients, and we have to be very clear on circle of care and where the information is stored.
Thank you. Yolanda.
Good morning. Excellent talk, Alison. Thank you. I guess my question too was a little bit along the lines of what Gary was just saying, which is part of me often feels that even when we're aware of sort of these social determinants of health, sometimes I feel I don't know how much of a difference we can make. I realize in a multidisciplinary team, there is the opportunity, to offer more like social services, but some things are very limited, housing and things like that. So I don't know. I guess that's a bit downstream of the work that you were doing, but I wondered if you thought about that as well.
Oh, Yolanda, it's such a good point. I think that a lot of what we're looking at here, when I think about Centretown, we deal with in our urban health a lot of those issues. But what we're looking at here is identifying them to understand how they impact that patient's health. So it's a slightly different focus. The way I would describe that is that if 3 children are sitting in the orthopedics casting room and they've all got the same fracture, and one comes from a middle-class family that can go and buy a special cast and has the money for those fancy colored ones and can read and can advocate for the child, and then the other one comes from a family where there's a lot of where there's less of an education level, where there's no funding, but they can, and the other one comes from a family where they can't read or understand anything that happens. Those 3 children, their healthcare is severely impacted by those social determinants of health. And while we can't change the social determinants of health, could we help those arms to heal equally if we thought about the issues of making sure the information was at a literacy level that everyone could understand? Do we have translation? Maybe we can get someone in to translate for that. So that was kind of what we were looking at in this study, much more not solving all the problems, but having them have a lesser impact on that child's healthcare at this event.
I can see that Simone has put a question in the chat here. She's working with Dr. Zukovic and others at CHIO interested in screening for SDOH. They've put together a brief tool for that purpose. Is there a tool you really liked?
Excellent question. We didn't actually really look at all of the other tools once we realized there was a whole bunch of them. I think that from what we have seen, the tool needs to be quick and facile. It needs to not assume a high education level, and people need to be trained to use it. And it needs to be something that can be passed along quite quickly. So did we actually, I didn't know, I can't say we looked at all the tools for that criteria, because that wasn't really what we were doing. But I'm very excited that you're doing that work, Simon, and would love to chat about it.
And I can see one other comment here in the chat from Laura. Great work, Alison. The CHCs try to collect a lot of this kind of information from patients, and many do not wish to provide it. I hear comments that they don't see how it is connected to their health or healthcare. Did this come out in your survey?
Oh, yeah. I think that's Laura, thanks. That's a great comment. We do collect a lot of information. One of the is that when we collect that information, we never collect it again, and it stays with the person forever, which is a huge issue with electronic health records and how they move forward. I think one of the things that the people who are participants in this survey really emphasized is that people need to know why you're collecting the information, and they need to understand, is it going to have an impact other than stigmatizing and judgment on them? And I get that. That just makes so much sense. So I think it goes to the sense that people really felt there has to be training, and that the tool need the information. We have to respect the information we collect as being precious every time we collect it. And I totally think you're right. In the health centers, we definitely need to be very aware that if we collect information, the patient understands why, and that it is only used for a positive, it's only used to benefit them. And I think just yesterday we were in Canadian clinic, and we had a huge discussion about these issues between, there was a resident, myself, a nurse, and a social worker about information and what we were going to do with the information. And I also think that continually talking about it and checking back on our ethics and discussing, and I think that's one of the benefits of the teams, but we do always have to ask these questions. Even as we use tools, we have to constantly ask, are we doing the right thing? Which is why I would say I love having learners, because I find that the young, particularly just new people, new eyes, ask these questions in so many brilliant ways.
Alison, thank you very much. Please keep your comments and questions going in the chat. We're going to now move to our second presentation. And before we do, though, I do want to take this time to advertise our research community of practice, which meets on the first Thursday of every month. So this next one coming up on Thursday, November 4th from 10 to 11:30. The reason why I'm advertising this right now is because Bill Hogg will be talking about provider recruitment in research. So if this is of interest to you, please tune in. If you need the link, just send me an email or get in touch with Maddie Venables. Okay, so our next presentation, a very interdisciplinary, interprofessional, team-based presentation here. It'll be started, Dr. Carol Geller, who did her medical school training at University of Toronto, and she is a family doc and has been with the community, with the Centretown Community Health Center since 1998. Major focus of our practice is working with people who are marginalized, secondary to reasons such as homelessness, poverty, mental health, and addiction issues, and refugees. Andrew McClellan is a primary care nurse practitioner, currently completing a doctorate in nursing at the University of Toronto. He's worked with urban health program at Centretown since 2013. Andrew holds multiple academic appointments. He's a lecturer with the Faculty of Nursing at the Muhimbili University in Dar es Salaam in Tanzania. He's an adjunct professor with the Department of Family Medicine here at University of Ottawa, and a teacher of the University of Global Health Equity in Rwanda. Andrew has interests in global health, healthcare education, policy, and research. Ms. Soha Karsand is a second-year medical student here at the University of Ottawa, and she has an interest in social determinants of health and continues to work with marginalized communities. Ms. Karina Lacombe is a clinical psychology doctoral student here at the University of Ottawa, and she has conducted interdisciplinary research ranging from vision and cognition to marketing and clinical. So, Carol and team, over to you.
Good morning and thank you. So I have to say part of this started because Doug got hired and I told him that I couldn't stand research. And Doug, congratulations, we're now here. And it has been a huge learning curve. So feedback to family medicine, good idea, with the whole vision of how you get us involved in research. So we have had this team going in various permeations and combinations. Alison gave you some of the history, and I'll take the history a little bit further back. This mandate for Centretown started in 1998 under the Harris government, where there was funding that went into homelessness. And I remember my interview, just to show how steep the learning curve was, where I was asked, what do you think about harm reduction? And I remember saying, I don't actually know what it is, but it sounds like a good idea. So we've come a very far way since that time. So this clinic now is, I'd have to say, the most amazing model as a clinician, and we wanted to look at it. So we're looking at primary care for our urban, marginalized, and complex populations. And we wanted to evaluate our model and look at health literacy of those we serve. Next slide, please. So our objectives of our study and of this talk were to actually explore the terms urban marginalization, patient complexity, and health literacy, and how they actually affect primary care access. We want to present our actual program at Centretown, and we want to provide an overview of our project, the evaluation and look at health literacy. Next slide, please. Okay, so this is our actual mission statement and vision at Centretown. which we thought was very interesting in looking at this program that's come out of a specific population we serve. Mission statement is to lead the way in improving health and well-being for people and communities. Our vision is health equity for all members of our community and working as a collective to address the systemic barriers and challenges to accessing health services. And then I thought the strategic direction was interesting, to enhance access for people with complex needs. Next slide, please. So this is kind of the definitions that we used within our study protocol, is to look at what marginalized populations are, and this is how we define them. Those are people who are excluded from accessing the mainstream social, economic, cultural, or political life for many, many reasons that do include gender, culture, language, race, sexual orientation, and socioeconomic position. And certainly this speaks to me from experience. This includes people who are homeless, those with addictions, street-involved youth. The shelter is actually directly across the street from us. Those who've been in the correctional system, and we have many halfway houses within our community, Aboriginal people, and people with mental illness and racial minorities. These people do reside within an urban setting, and certainly within Centretown, and frequently share common social determinants of health related to their exclusion and poverty. Next slide, please. So then you look at the complexity, and I'm sure this speaks to many people who provide primary care or provide clinical care. The challenge of providing standard care as a result of the severity of their psychosocial and medical conditions. The lack of their behavioral readiness to engage in their healthcare. What is our priorities is often not their priorities. Medical care is often not even their priorities. A lack of social safety for them or ability to participate. And my goodness, I'm sure this speaks to many people, the lack of coordination of care or the difficulty they have in their care system relationships. Next slide, please. Literacy, I think, speaks to a lot of what Alison gave us her examples of those 3 children getting CAS. It's the skills and cognitive and social skills which determine their motivation and their ability to gain access to, understand, and use information in ways that promote and maintain good health. And these are examples of what low literacy is associated with. And I think Kevin Potty did a lot of great work on that with his work on homelessness and New Canadians. Next slide, please. Barriers, and again, I think this speaks to many, and we have so many learners in this clinic, and I really do hope these concepts come across. They often experience stigmatization. In fact, I think we all know that they often will tell us they're not going back to that emergency room or back to that hospital because of how they felt discriminated against. They encounter practices and policies where they feel judged or disrespected. It again speaks to many of the things Alison said. And as a result, they'll avoid accessing similar services in the future. The fact that often they don't have an address, personal ID, access to a bus tickets or a way to get somewhere, telephones to give them information about appointments and follow-up, and social supports to allow them to negotiate and navigate the system. Those are such common barriers that we see within urban marginalized populations. And for the newcomers, on top of that, we have a combination of economic, geographic, cultural, and language barriers that limit their access to healthcare. Next slide, please. So this is a description of our program. And this came from kind of years of experience, to be honest, and actually it's kind of neat to see how much some of it now matches the literature. But we've basically come up with what Alison's described, which is it's flexible, it's drop-in. In recent years, actually, we started offering booked appointments for those who seem to be progressing in their stability in their healthcare. Often we see this as a graduation to becoming integrated into main care systems, or appointments supported by partners like CMHA workers. We have wraparound with socials, and I think Yolanda made a very good point about what do you feel you can help with. To be honest, I feel we can help with a lot of these things, helping with housing, helping with ID, things like that. We have shared care with a psychiatrist, and we have amazing outreach. And you'll see our inclusion criteria below. Next slide, please. Okay, over to Andrew.
Hi, yeah, so we designed a project to apply for a prime grant, and I think we got it in 2018. And so this has been a bit of a voyage. And we wanted to look at two things. So the first phase of our project was a program evaluation, and we wanted to conduct this evaluation to ascertain if our program was achieving our stated goals of providing comprehensive care to this population. And the objectives was to do a fidelity assessment of the program with the aim to determine the program's health service quality and looking at approachability, acceptability, availability, affordability, and appropriateness. Explore if, when, and how the program provides access to primary care for this population. And we wanted to describe the program's best practices in engagement of providing services for marginalized and complex urban populations. Next slide, please. So, and then the second phase, informed by the evaluation, confirming that we are in fact engaging the urban, marginalized, and complex populations in our catchment area. We wanted to, well, we did a mixed method inquiry exploring whether a tailored program such as this one, serving this population, can affect health literacy. And so our research question was, how does a tailored and comprehensive primary care model designed for urban, marginalized, and complex populations affect individual health literacy 3 to 5 years post the initial contact? Next slide. So we did use a evaluation and research conceptual framework. We used the patient-centered access to healthcare conceptual framework to guide the evaluation. The framework explains that increased approachability, acceptability, availability, affordability, and appropriateness of primary care services are associated with reductions in hospitalizations, emergency room visits, and unmet healthcare needs. And within the framework, we added some evaluation domains for the program evaluation, such as the structure of the program, the process, and moving towards the outcome. So this is going to help us write the paper and help guide a lot of the tools that we chose to do this project. Next slide, please. So in the first phase, the method of our program evaluation, we used a number of different methods. So we used, and we're going to explore them individually. We used the complexity assessment, and we did a prospective sample. Well, we haven't done, actually, this is one of the tools that we have not done. We're going to do a prospective sample where we'll be doing a complexity assessment on each patient that comes to the program for a 30-day period. And I'll talk about the tool in a second. We did an electronic medical record data pool to provide a snapshot of the clients that we saw throughout the year, and a bit of a patient profile of who we were engaging with. There were interviews with clients, a satisfaction questionnaire with clients, and then we did go and speak with key informants and partners to do interviews with them as well to talk about our program. Next slide, please. So the complexity assessment tool so we use the clinic complexity assessment tool, often known as AMPS, and it uses 4 domains to try to measure complexity in patients. So the first one is attachment. So does the client have an ongoing relationship with the primary care provider to follow up on health issues? M for medical, to determine the severity of symptoms and any challenges with the management of medical problems. P for psychiatric and mental health and addictions, to determine severity of symptoms and mental stability and cognitive function of the patients. And S for social, being to determine the social determinants of health that may be directly impacting the client's health and our ability to manage it. Next slide, please. And then so the second, sorry, back to the AMPS. We're going to do that for a month, as I said, and we're looking forward to doing that, I think, in before the end of the year. So with the Emr Data Pool, we pulled data between July 1st, 2020 and June 30th, 2021. And we looked at total number of unique clients, total number of face-to-face visits, the frequency of the visits, the type of insurance the clients had, housing status, financial situation, their financial situation, and chronic diseases. So next slide, please. So when we were looking at visits to the clinic, we saw 570 unique clients with a total of 1,856 face-to-face visits in the clinic during that time. And the frequency of client visits had an average of 25 visits per person with a median of 2 and a mode of 1 visit. Next slide, please. So when we were looking at healthcare insurance, knowing that insurance can obviously be cause a barrier to access, and people without primary care providers. So specifically in this group of this population group, we were wondering how many people had no coverage. So in terms of not having any coverage at all, 15% of the people that we saw that year had no coverage, no HIP. 19% had intrafederal health, which also can cause limitations in access of primary care. So you can see that that's about 34% of people didn't have full OHIP. Next slide, please. So this was the housing situation. So we did for the data pool. We first did it by address. So when you do electronic medical pool, it was basically the addresses that were in the medical record on that day of the poll. So we can see that at that time, there were 8% of people that were in shelters, 9% with no fixed address, 11% in rooming houses, and 72% had, I wonder where I can't see the numbers for the end codes, but 72% that had an address. But then we decided that it didn't seem representative of the people that we were seeing, because we often do see homeless people. So we did pull by N codes. So N codes are codes that are inserted by clinicians into the client's medical chart to indicate if the client was homeless or living in a rooming house throughout the time of that the patient was engaging with our program. And with that, we saw that about 52. I think this says 52. Can you guys see the numbers underneath here? Or? No. Okay, so the blue section here is 52%. I believe it was 52% that were homeless, and I think it was 19% that were in a rooming house. Thank you. Claire Liddy says 53. Okay, so maybe it's 53%. Yeah. Okay, I can't see them. I don't know why. But, anyway, so all to say that a lot more people were transitioned from housing, from being homeless into rooming houses and back. And when we're looking back, we can see that we're engaging quite a few people that are homeless or living in rooming houses. And rooming houses, just to be clear, are tenant shared, how their individual rented rooms in a house that are usually have shared bathroom and kitchen. Many of the rooming houses are in poor physical condition. People that reside in rooming houses are generally defined as vulnerably housed and are at risk of returning to homelessness or becoming homeless. Okay, next slide, please. So in terms of client reported income, I think this is quite interesting because we didn't have all 570 people report their income, but of the 219 people that did report their income, 81% of them reported their income to be between 0 and 15,000, and 11% between 15 and 19,000 dollars annually. And according to the 2018 Opportunity for All, Canada's first poverty reduction strategy done by Social Development Canada, the poverty line for annual income for individuals is between 16,000 and 20,000, depending on the location in Canada. And in 2019, 10% of the Canadian population was calculated to be at the poverty line. So in these 219 individuals, you see a 92% rate of people that are either living at the poverty line or below it. Next slide, please. So in terms of chronic illnesses, we did find that of the 570 individuals that we saw that year, 10% had diabetes, 18% had hypertension, 6% with hepatitis, 2% with HIV, 7% with latent TB, and upwards of 30% with psychiatric disorders and substance use, which was predominant. Next slide. And this is just a bit further characterizations from some N codes that were put into the client's charts. We did find that 26% had problems with refugee claims, 17% with language barriers, 27% with immigration issues, and 20% reporting problems with the healthcare system, So that was from the data pool. So interviews with clients, and we're going to hand this off to Soa.
Morning, everyone. So I'm going to be talking about the client interviews today. So the purpose of those interviews was to get quantitative and qualitative data about the client's experiences with the urban outreach program. So essentially in those interviews, we were asking clients about the program, their use of the program resources, their current life situation, including their living arrangements and their financial situation. And then we also asked about their overall satisfaction with the program. So we recruited 31 participants via convenient sampling just at the clinic, and 15 of those participants were from the newcomer clinic, which is the immigrant and refugee population, and 16 were from the urban outreach program, which is the more traditional Canadian marginalized population. Next slide, please, thanks. Okay, so of the 31 folks that we spoke to, 17 lived in rooming houses, shelter or the street, 10 were refugees, 7 were immigrants, 26 reported difficulty making ends meet, and 12 reported financial barriers to healthcare. Next slide, please. And then we also asked all of the clients how many of the services at the program they were using. So for example, were they exclusively accessing medical services, or were they also accessing psychological services, harm reduction, social supports, etc.? So of the 31 that we spoke to, 27 of them used more than one of the services at the program. Next slide, please. And then we put all of the interviews into in vivo, and this is just an example of the first word tree that came out. So the words in the center were the words that came up most frequently within the interviews. And then as you move out to the sides, it's the words that came out less and less frequently. And we use those to establish some of the themes from the interview. Next slide, please. So we did a preliminary thematic analysis of the interviews, and some of the major themes in terms of the positive aspects of the program that came out was the friendliness and the availability of the staff, the availability of multiple services within the one program, and the convenience regarding the location of the program. And a major area of improvement that was identified was the lack of continuity of care. So here, what the clients were speaking about was the fact that they felt that they saw different providers every time they accessed the clinic, and they wanted more follow-up with some of the staff from the clinic. Next slide, please. So here I've just provided a couple of examples of the quotes that came out from the interviews. Next slide, please. And now we're going to talk about the client satisfaction tool. So next slide, please. So this was just at the end of the interviews that we did with each of the participants. And this was a validated tool that was initially an 8-item survey. We used 5 of those items in our questionnaire. And this is the purpose of this interview was to just get an estimate of the general satisfaction with the services in a quantitative way. So again, we administered these to the same 31 participants that we did the interviews with. Next slide, please. And each of the questions were scored on a scale of 1 to 4, with 1 being the lowest and 4 being the highest possible score. And then we took an average of each of the 31 interviews that we did. So I've just listed the scores for each of the questions and the questions here. As you can see, the feedback was overwhelmingly positive. So all of the scores were above 3.5 for each question that we asked. Next slide, please. And now I'm going to move on to the key informant interviews. Next slide, please. So these were interviews that we did with partners of the, staff of partners of the program, as well as some staff of our own program. So we did 10 interviews overall. 3 of those were done with staff of Centretown, and then 1 was done with staff from YSB, 2 from Cornerstone, 2 from Center 507, and 2 from the YMCA. Next slide, please. And once again, we did a preliminary analysis of the major themes that came out from those interviews. So in terms of the positive aspects, it was actually almost identical to the aspects that came out from the client interviews. So once again, the friendliness and the availability of the staff, the convenience regarding the location of the clinic, and the availability of multiple services. And in terms of areas of improvement that came out, the major one that people were mentioning was the booking, referral, and appointment process. So here they were talking about how they felt that their clients had to go through a lot of different hoops in order to be seen by a provider. The next one was the hours of operation. So here they were talking about how the clinic was only running two days a week, just in the mornings, and that was creating a bit of a barrier for some of their homeless population. Next slide, please. And here I've just given some more examples of some quotes from those interviews that you can take a look at. And I think that's it on my end. I think we're on to Curry now.
So I'll just restate the aim that was stated a little earlier by Dr. Geller. But essentially what we hope to do was assess health literacy in marginalized community using either services at the Centretown Community Health Center versus other locations. And many of those locations are the ones that SOHA had previously identified. And so just as a recall, the way that we were identifying or defining health literacy was through the World Health Organization's definition. So the cognitive and social skills, which determine the motivation and ability of individuals to gain access to, understand, and use information in ways which promote and maintain good health. And the reason that we want to really assess health literacy is because it's associated with a slew of different factors. And so a couple are just named over here. So for instance, increased mortality, increased hospitalization, poor adherence to medication use, decreased knowledge, etc. Next slide, please. And so the way that we went about assessing health literacy was through a measure called the Health Literacy Questionnaire. So pretty easy to remember. This is a 44-item survey, which takes approximately 15 to 20 minutes to administer. Given that I'm luckily bilingual, I was able to administer this both in English and in French, depending on the preferred language of the client. And overall, what this tool assesses are 9 different factors of health literacy. So for instance, feeling supported and understood by healthcare providers, having sufficient information to manage their health, actively managing their health, having social support for their health, whether or not they're able to have appraisal of health information, whether or not they're able to actively engage with healthcare providers, whether they can navigate the healthcare system, whether or not they're able to find good health information both on their own and through the help of others, and whether or not they're also able to understand health information well enough to know what to do about it for themselves. And so ultimately what we did is recruited a total sample of 73 participants or clients, 37 belonging to Centretown Community Health Center. Within that sample, we divvied that up into 2 subgroups. So 16 were from the urban outreach program, so from marginalized communities, and then 21 were newcomers, so from the newcomer program that SOHA had previously mentioned. Among the other locations, we recruited a sample of 36, divvied up again through the same other locations. So the YMCA, the Cornerstone Women Health Center, Center 507 drop-in, and the Youth Service Bureau. Next slide, please. And so if we look overall at the demographic information that we collected, what's especially important, I think, in this slide is that the majority of our sample was either unable to work due to a mental health or physical chronic illness or disability, or were unemployed. And a big factor of that was also, unfortunately, COVID. Another important thing to mention is that 50% of our sample was currently suffering from a mental health or a mental health and physical illness. Next slide, please. And so if we look at our results overall, the only one that really stood out where we found a significant difference between the individuals at Centretown and other locations was on appraisal of health information. And so over here, what we can see is that individuals that sought services at Centretown had significantly higher appraisal of health information. What this means is that they were able or better able to identify good information and reliable sources of information. And so an example of the type of question that we would ask pulled from the questionnaire is, I ask healthcare providers about the quality of the health information I find. Next slide, please. However, overall, what we see is that across the scales, so scales 1 to 5 again, overall assess receiving support, connection with healthcare providers. Here we can see that overall their health literacy at both locations was pretty good. And from scale 6 to 9, which assesses finding and understanding health information and navigating the healthcare system, again, between the sometimes difficult to easy range. So a little bit higher than maybe what we were expecting. So good finding. Next slide, please. And so overall, if we take this all together, what do we find? So what we've noticed is that members within marginalized communities have several and pretty significant multiple chronic physical and mental health issues. That health literacy among marginalized communities is fairly consistent across locations, so both at Centretown and other locations. But that clients at Centretown have greater appraisal of health information. And that lastly, individuals from marginalized communities have pretty good or adequate health literacy. Now, the reason I put a star next to this is because unfortunately the tool doesn't really have a number indicating what high versus low health literacy means. And so if we take the kind of the middle point as being anything above that high, then we can say that, you know, they had pretty good. Ideally, what we would want to do is kind of compare this to a normative sample, which we haven't had the chance to do yet. Next slide, please. But ultimately, what we want to do is really dive into this a little bit deeper. And so part 2 of this is essentially assessing health literacy on a deeper, more intimate level through the use of focus groups. And so we're going to be using the same 4 groups that we used earlier. So again, newcomers and marginalized communities at Centretown, and then newcomers and marginalized communities at other locations. The focus groups are going to be roughly 6 to 10 individuals per group with an hour-long discussions about their experience with the healthcare system. Soha and I have already started this, and data collection is ongoing. So thank you so much. And this is, I think, Dr. Geller.
So closing remarks, basically, so far we've been able to do a fidelity assessment that we hope once complete will confirm that our program is engaging those who we defined as complex. The second phase so far has found that the type of service we provide is targeted at marginalized and complex populations, and we can influence some aspects of health literacy, and we look forward to sharing our final results.
Well, Carol, Andrew, Soha, and Karina, thank you so much for sharing. I think this has been a great example, is just to repeat what David has said here, the transdisciplinary lens that you've used for this program evaluation is terrific. And I think it also shows us too, you know, how program evaluation can lead, right? Your findings from the program evaluation can lead into to research. So I think that's a great example for us. We've gone over time. So if people, I see people are putting in their comments here, which is great. If you can stay for a couple of comments, if you have one that you'd like to share or question, please do. If not, we'll see you next month. Questions for our team?
Do you want to ask if the Prime grant is worth it?
Okay, there's our question. Go for it, is it?
I think so. I think, and I also think it speaks to the fact that I congratulate the Department of Family Medicine again on the interdisciplinary, because a lot of this is being led by Andrew as a nurse practitioner who cannot access kind of research for primary care without the support of family medicine. We're unique recognizing nurse practitioners.
Yeah, and the Prime grant's been also really nice because I have to say we've learned so much along the way, and you know what to do and what not to do, and I think it will help for the future and designing programs and well, doing further research as well. So thank you.
Great, thank you. Well then, I guess on that note, thank you to Carol and team and to Alison for your great presentations today. And please tune in next month. And if you get a chance to do your surveys, that'd be great. You can see our ad for research grand rounds next month. So with that, I bid everybody a fair adieu.